as well. So I'm Laura Wood, and thank you for joining us this evening for our workshop. What we're going to be doing tonight is providing some general education and a couple of little housekeeping notes. Number one, and most importantly, thank you to Merck for their generous support of this evening's workshop. So we are greatly appreciative of that. And for those of you that are on virtually, please submit your questions via the Q&A portal, and we will be happy as a panel group here to address those questions at the end of the program. And this program is being recorded, so it will be available on the Kidney Cancer Association video library in a couple of weeks following the program. And so with that, I am delighted and honored to have an esteemed panel with me. These are some of our Kidney Cancer Association Clinical Advisory Board members that are participating, and we have others of our Clinical Advisory Board here together, and we work very tightly as a team to help support the Kidney Cancer Association's efforts. So our agenda tonight is pretty simple. Provide an overview of the disease, talk about some of the diagnosis and the management, side effect toxicity management. Again, all of this is from the 30,000-foot view. So we won't be able to go into detail tonight, but we want to at least jumpstart the discussion. And we're going to incorporate case studies into the discussion tonight. So with that, just to provide a very brief overview of kidney cancer, and I'd like to go ahead, Virginia, and ask if you would give us kind of an update for especially the audience that doesn't know a lot or work a lot with kidney cancer about the kidneys.
Certainly. I know most people understand what the kidneys do, but just listed here are a few of the main functions: filtering waste and fluid, helping with acid-base balance, creating hormones that can control blood pressure and can produce red blood cells. Importantly, if you don't work with kidney cancer, it's good to know that patients can live a normal life with one kidney or 1.5 kidneys. If patients already have a pre-existing kidney issue, there might be some concern with that, but many patients and families and clinicians that aren't used to working with patients with one kidney, it would be good to know that they can certainly live a full life that won't limit them.
Great, thank you very much. And just give a little background on the statistics. We know we have almost 600,000 individuals living with kidney cancer. We've got about 82,000 new cases, and we lose about 15,000 patients estimated in this year. 5-year relative survival for all patients with kidney cancer is 77%. But our challenge is those individuals that present with stage 4 disease, their 5-year relative survival is 15%. And that's where a lot of our efforts over the last number of years, and yours helping support research and clinical trials, has made the difference for these patients. So Nancy, talk about the signs and symptoms and risk factors.
Sure, definitely. I see a lot of newly diagnosed kidney cancer patients, and some of them even before they have their surgery. So one of the first things that they will say to us, well, how did I get this disease? And at that point, we talk about some of the known risk factors associated with kidney cancer. We know that patients that have a history of smoking or obesity can predispose one to develop a renal carcinoma. High blood pressure, chronic kidney disease, patients that are on long-term dialysis. There are some occupational exposures that predispose patients to develop a renal cell carcinoma. And then there are some genetic factors, and there's actually some genetic disorders that patients will have that will predispose them to developing a cancer on their kidney. What we know is that it's more common in men. We see most patients kind of at middle age, between 65 and 70. It's more prone in African American patients and Indian and Alaska Native. So once you identify what the risk factors could be in patients, and not everybody is going to have these risk factors, many patients will present without any symptoms at all. For those patients that present with a symptom, it could be like any other type of malignancy. They could have a loss of appetite. They could be fatigued. For patients with kidney cancer, we will always ask, well, did you have any blood in your urine? Are you having any flank pain? And just sometimes an unintentional weight loss. So we have risk factors that are kind of soft in terms of what we can do to actually decrease our incidence of kidney cancer. And then we have signs and symptoms, which usually are indicative of advanced disease.
Great, thank you. So Zita, why don't you talk about subtypes and staging for kidney cancer?
Certainly. So kidney cancer, approximately 3/4 of all kidney tumors consist of clear cell renal cell carcinoma, or what we used to call conventional renal cell carcinoma. And that's the one that's mediated by the VHL tumor suppressor gene. And that's actually the one that's probably been the most heavily studied one. That's where all the trials have been conducted. But then we need to be reminded that there's another quarter of kidney cancer patients that are represented by these other subtypes. The next most common is papillary, followed by chromophobe, collecting duct, renal medullary translocation, and then finally unclassified. And these are treated differently, have different levels of aggressiveness, but we'll be focusing mostly on clear cell with today's presentations. And then kidney cancer has 4 stages. We basically, stage 1, it simply means it's limited to the kidney and is under 7 centimeters, which if you're going to use, to explain to your patients, you can describe it as being about the size of a tennis ball. Stage 2 means it's above 7 centimeters, but is limited still to the kidney, whereas stage 3 means it is already extending into the vasculature, into the renal vein, IVC, or into the renal sinus fat. And finally, stage 4 means that it has metastasized to other organs. Next slide.
Okay. Then Nancy alluded to the number of hereditary syndromes that we do know are causative for renal masses, and we have the first FDA-approved therapy for the VHL renal mass, so that we have treatment there. The others we continue to work on for new drug development. So Nancy, we've made huge progress since you and I first started in this era of kidney cancer treatments. And why don't you talk about where we are now?
Sure. Happy to share this slide with the audience. And I'd like to start with the right-hand side, which really talks and speaks to the tremendous advances that we have made since 2005. If you look back at 2005, it was all single agents that were used to treat kidney cancer that was metastatic. But now we are really in the exciting era of combined therapies where we have immunotherapy, we have a targeted therapy, and really the challenging question is which one are we going to select to treat our patients. So this is an extraordinarily exciting, we talk about this all the time. Prior to 2005, we had 20 years with one drug, and now we have 15 drugs. So better choices for our patients. And, I like to think that we're increasing quality of life. We're certainly in improving survival. And, I think we'll get into more discussion of these agents as we hear the case studies.
Great. And speaking of case studies, let's talk about diagnosis and management then. And why don't you grab one of the remotes, Nancy, and take us through the first case study?
Definitely. Happy to talk about a patient that currently still taking care of with a small renal mass. And I just wanted to say that most small renal masses are found incidentally. I mean, patients not going to come to you and say, I think I have a small renal mass. They are found incidentally when a patient might go to the emergency room because they've been in a trauma event. They are being worked up for another problem and they have a CAT scan of their abdomen and they find a small renal mass. So over 50% of renal carcinomas are identified this way. So this particular patient was 24 years old and just went to his GP and ended up with saw a gastroenterologist with just some vague abdominal discomfort. An ultrasound showed a cystic mass in the lower pole of the left kidney. Medical history was negative, healthy 24-year-old male. with a family history significant for papillary thyroid cancer, melanoma, and prostate cancer. Diagnostic testing that was done on this patient, blood work, chemistries, hemoglobin, all normal. Imaging studies, he had a CT of his abdomen, which actually showed a 3.6 centimeter left renal mass that showed what we call solid and cystic components, also located very close to the collecting system. And then the patient also had an MRI, which the results were surprising because we actually saw two lesions, one 3.6 and one 2.7 centimeters. A CT of the chest was done that was normal. For this particular patient, a biopsy was not done. And in kidney cancer, there is no current biomarker testing. There's not a routine blood test or a biomarker that we can run on patients to see whether or not this would be a renal cell carcinoma. But the things that one think about when someone has a renal mass, you think about the age of a patient. And for this particular patient, he was 24 years old, so that did raise a lot of red flags for us. But just in general, when you're working up a patient with a small renal mass, you think about what type of comorbid diseases do they have? High blood pressure? Do they have diabetes? What is their kidney function? So there's a very well-orchestrated kind of song and dance that you do when a patient has a small renal mass to make sure that the appropriate surgery or not surgery is suggested for the patient. And then getting back to this case study, his age was a red flag for us, so we sent the patient for genetic counseling. I should say genetic testing. So when someone has a small renal mass, the surgical options are either a partial nephrectomy versus a radical nephrectomy. And I've been doing this a long time, and I remember when partial nephrectomies were just being used in the operating rooms and by the urologist. And it was, oh my goodness, how are we going to take a small piece of this tumor out, and how are we going to sew the kidney together? And there was so much talk about it and so much research. And now, it's kind of standard of care. The surgeon removes the tumor and able to, if in the skilled hands of the right surgeon, able to sew the kidney back. Sometimes patients will have to have a radical nephrectomy, even if it is for what we call a small renal mass, and that's depending on the location of the tumor. When they do a radical nephrectomy, they simply remove the kidney, they remove part of the ureter, and it's gone. And as Virginia said, patients can live normal lives just having one kidney. So the results from the surgery, the pathology and staging, were very interesting. The pathology showed a renal cell carcinoma that had features suggestive of what we call an MITF family translocation. The Furman grade was a G2, there was no invasion, it was a negative margin, and the patient was staged as a PT1A. And the reason why they are calling this tumor with features suggestive of an MITF family translocation was because of some of the staining that was done on the tumor in pathology. So there was some, stains that actually showed positive that it might be a translocation. And then the results of his genetic counseling showed that he actually had a genetic mutation, and it was what we call the FH genetic mutation. And this particular gene is consistent with what we call hereditary leiomyomatosis, kidney cancer. So what to do next for this patient? And we had to turn to the guidelines, the NCCN guidelines, and really determine what would be the best way that we could follow this patient. For stages 1 and 2, which would be early stage kidney cancer, the NCCN guideline does recommend an annual history and physical with labs. For stage 1, baseline imaging about it says 3 to 12 months post-surgery, then annually for 5 years. Or for stage 2, we do the imaging every 6 months for 2 years, then annually for 5 years or longer. Now, I have to say that in our practice, we really do more tailored imaging based on the patient. And we look at, did the patient have positive margins? Did they have a higher Furman grade? And did they have any adverse pathologic features? Well, this particular patient was followed for 5 years, every 6 months, and is 7 years disease-free. So he's doing quite well with having, a pathology report with some, perhaps an aggressive type of cancer, and also having a genetic mutation that predisposed him to developing the kidney cancer.
Great, thanks,
Yeah.
Nancy.
Sure. Yeah. And so now we're going to move from a small renal mass to a patient that would present with what we call localized disease. And my colleague from MD Anderson, Zita Lim, will present case study number 2.
Thank you. So this is a patient of mine who is a 45-year-old female patient. She's a high school teacher who she herself had palpated an abdominal mass and brought it to the attention of her primary care physician, who then ordered abdominal imaging. And sure enough, there was a 10.8 centimeter right renal mass. And at the time, there was a concern that perhaps it was invading the liver. But further testing showed that there was no obvious metastases. Her past medical and surgical history were unremarkable, aside from 2 C-sections. So she underwent the right radical nephrectomy with regional lymph node dissection, and the pathology was positive for an 11.5 centimeter clear cell renal cell carcinoma, Furman grade 4, with positive necrosis and invasion of the renal vein. So this was then therefore staged as PT3A, and one out of 6 lymph nodes was positive. At the 8-week mark, post-operative scans were negative, and her labs were normal. And so she was referred to us at this point for consideration of adjuvant therapy. So what do you do next? And these were the questions that you ask yourself. One is, should you offer the patient postoperative radiation therapy to the renal fossa? Or perhaps we treat her with sunitinib for 1 year. Should we offer her nivolumab and ipilimumab for 1 year? Or would you offer her 1 year of pembrolizumab? Or would you suggest active surveillance without adjuvant therapy? So what did we do? Well, we did not suggest radiation therapy to the renal fossa. The reason is there was a meta-analysis done of 12 studies that looked at over 1,600 patients, and they saw that adjuvant radiation therapy was not associated with better disease-free survival or overall survival at the 5-year mark, although it did reduce the local regional recurrence. How about sunitinib? Well, we also didn't offer sunitinib. Now, granted, there was a positive phase 3 trial that was called the S-TRACK trial, where patients were treated with sunitinib. They did have a longer disease-free survival. However, the grade 3 adverse events were 63% versus 21% on the control arm. But there was no significant median overall survival advantage. And in fact, other VEGF TKI trials were all negative. So with that in mind, the NCCN guidelines have listed this as a category 3 recommendation. How about nivolumab ipilimumab? Well, that too was presented recently at the ESMO 2022, and that trial was the Checkmate 914, and that was a negative trial. Interestingly, there were 2 other immuno trials that were negative presented at that same conference. Emotion 010 with the atezolizumab, and Prosper trial with nivolumab. All 3 trials were negative, so we wouldn't offer nivo-ipi in this setting. We did offer her 1 year of pembrolizumab. And this is based on the Keynote 564. This was a phase 3 trial in which 994 patients were randomized 1-to-1 for 1 year of adjuvant pembrolizumab versus placebo. 24-month disease-free survival was 77% with pembro versus 68% with placebo. Interestingly, patients showed the greatest benefit were patients who had M1 NED. So that means they had a resected metastatic site. I do need to update this slide. Actually, the overall survival has not been published, but the Merck has announced recently on November 1st that they did reach their overall survival endpoint, and it will be most likely announced. The details of the trial will be announced probably at GU ASCO. And active surveillance is also a legitimate option. However, this is not the option we chose for her. But if you did choose to do, the imaging guidelines would be, you could follow the NCCN recommendations. And you would actually follow the same recommendations whether the patient was treated with pembrolizumab or not. You would still continue surveillance even if a patient received adjuvant therapy. So what are some considerations about adjuvant therapy? Well, first of all, it would be offered to patients who meet intermediate high or high risk of recurrence. They would have clear cell histology, and sarcomatoid features also showed benefit. How do you determine that? Well, there are some handy tools out there. One is the Assure RCC prognostic nomogram. That can be found on the Fox Chase website. And it's very user-friendly. You just enter in these different data points about your patient. So if we look at my patient, for instance, she was 45 years old. Her tumor was 11.5 centimeters, clear cell, grade 4, necrosis. She basically checked all the boxes aside from sarcomatoid features. And with that in mind, she was considered high risk with a 66% chance of recurrence at 1 year. So with that in mind, that's why we opted to treat her with pembrolizumab. And she did complete 1 year of pembrolizumab, and I actually saw her just a few weeks ago for her 15-month post-op visit, and she remains without evidence of recurrence. Now, she did develop some toxicities, mostly grade 1 arthralgias, which we managed with tramadol and topical diclofenac, and those have since improved since she stopped treatment. What are some other considerations when treating patients with adjuvant pembrolizumab? Well, safety is an important consideration. About grade 3 or higher adverse events occurred in about a third of patients treated with pembro versus 17% on the control arm. Cost is a consideration. It costs about $500,000 for 1 year of treatment, at least at MD Anderson. And also travel and time. These are otherwise healthy patients who, will have to take time away from work every 3 to 6 weeks for a total of 9 to 18 infusions, depending on how you choose to administer the treatment, whether it's every 3 weeks or every 6 weeks, right? And then the other considerations are, of course, whether or not the patient has autoimmune disorders, right? If a patient has active or quiescent autoimmune disorder, we would not offer them pembrolizumab. Significant cardiovascular disease, if they have second primaries, or other significant life-limiting comorbidities. Other nursing considerations that I think we should keep in mind are, it's important that we educate our patients about potential IO toxicities. Also setting their expectations. I find that, patients who have no evidence of disease and are getting potentially developing toxicities, it's much harder for them to accept that and tolerate that than perhaps a patient who has stage 4 disease and is fighting for their life. There's a different expectation there. And then also it's important to point out that, the follow-up is going to be the same. So if a patient thinks that, well, if I have the treatment, I never have to come back to your office again, that's not the case. We still have to continue monitoring you. So with that, let me pass the baton to my colleague, literally pass the
Literally,
baton.
yes, literally.
And she'll talk to us about advanced disease. Go ahead.
All right.
Virginia.
So this is the third case study, and it's one about advanced disease, and I'm sure a lot of us take care of these patients. So this is a patient in our clinic, a 57-year-old gentleman who had a history of stage 3 clear cell RCC, and he had had a nephrectomy 3 years prior. We were doing our routine surveillance imaging, and he had developed some new lung nodules and a perinephric nodule. Thankfully, he was feeling well, aside from some mild fatigue, but was working full-time, really not having any true symptoms of his disease, what we assumed was disease at the time. So we had checked some baseline labs, and he had a bit of worsening anemia here. His other labs looked pretty good. A CT-guided lung biopsy was performed, and it showed that this was clear cell RCC, so it documented recurrence. We did not do any routine biomarker testing. I know different institutions do at different times. We did not do that. His other comorbidities were considered because we were thinking about what treatment options we wanted to offer him. And he had a history of hypertension, well controlled on lisinopril daily. And he had a distant remote history of psoriasis 20 years prior, but had not had any joint problems and really had not had any active problems with this. So his treatment options were fairly wide open. So one of the factors, or one of the models that we often look at for patients who have advanced disease is the IMDC prognostic factor prediction tool. And Heng and colleagues developed this back in 2013, and this was in the era of tyrosine kinase inhibitors. So I think that this is one of the factors that people often use trying to figure out how patients are going to do overall, and also to choose what treatment might be the best option for that patient. And so as you can see here, it involves looking at their Karnofsky performance status, if it's higher than 80, if their time from diagnosis to treatment is less than a year, if their hemoglobin is low, or their neutrophils, platelets, or their corrected calcium is high. So for each of those factors, you sort of tick the box, and if they have none of these factors, they're considered to have favorable risk. And if they have one or two, they're considered intermediate risk, and if they have 3 or more, they're considered poor. And as you can see from the graph on the right, as you would expect, the favorable group does better, their overall survival being 43 months, intermediate with an overall survival of 23 months, and poor risk having an 8-month overall survival. Again, I just like to point out that this was in the TKI error, so I think that generally I would say we do better than this today. So taking those factors into consideration, it's really nice we have this problem. We have a lot of different treatments, first-line treatments for advanced RCC. We have the ipilimumab-nivolumab combination approved based on data from Checkmate 214, showing particular benefit in the intermediate or poor risk group. And then we have 4 combinations of immunotherapy and TKI therapy. And I won't go into great detail on each of these, but it's nice to have this problem back in 2005, when I think almost all of us still worked in RCC at that time. We didn't have a lot of options. You had maybe 1 or maybe 2. And so it's nice to have things to talk about with patients. And so for this patient, we took into consideration he was intermediate risk. And so his options would be either dual immunotherapy with a goal of treatment-free survival versus an IO-VEGF-TKI combination. So in discussion with the patient, talking to him about his goals, we proceeded to treat him with ipilimumab and nivolumab. He received 3 cycles and did fairly well, although by the time he got to dose 4, he had had some diarrhea. It was really just grade 1, but we were being very cautious with him, so we held his treatment, got a torso CT, and that showed improvement in lung and perinephric nodules. Diarrhea improved with loperamide, so we were reassured that this was not colitis. And then we began maintenance nivolumab therapy. So he was getting every 4 weeks, 480 milligrams of nivolumab, which he tolerated very well. He had no flare in his, very old history of psoriasis, and he did not have recurrent diarrhea. And subsequently, he's 14 months on therapy with stable CTs. His disease, he's not a CR. He did have initial shrinkage, but he has been very stable, tolerating treatment well. And I anticipate that when we hit the 24-month mark, that we will most likely stop his therapy, assuming that he continues to be stable. and hopefully he can enter treatment-free survival and go on about his life. So some things from a nursing perspective that you want to think about with patients and caregivers, letting them know what kinds of drugs you're planning to give them, how those work. What's the anticipated length of therapy? A lot of people ask that up front, understandably, because it impacts their decision. What types of side effects can we expect, and how would we manage those? And how often will we assess the patient with CAT scans to reassess how they're doing? And shared decision-making, I pointed out with this patient, he was an educated patient, as a lot of our patients are now, and he had an opinion about what he wanted to do. So together with us, we sort of came up with this plan together, and it's really important to take that into account so that we have buy-in from the patient. Of course, cost and prior authorization, always an issue. As Zita pointed out, the cost of these drugs is incredibly high, and time away from work, and if they get a side effect, then they can't work. So we want to be careful not to create a financial toxicity for these patients. So very important to get prior authorization information and let the patient know what that's going to look like. And then in our clinic, we really try with our advanced RCC patients to loop in our palliative care team early so that we're not pulling them in 2 years in when the patient's sort of doing poorly. We want to have them meet the patient right out of the gate so that they can also help us with side effect management of the therapy. And that way they establish a relationship with that team. Obviously, I work in an academic medical center where we have the beauty of having those patients seen by palliative care clinicians when they come in, which is nice. And now we'll move on to some patient care considerations.
Wonderful. Well, thank all three of you. Thank you, Virginia, Nancy, and Zita, for the case studies. For those of you online and for those of you here in our live session, please, if you're online, submit your questions through the Q&A portal. For those of you in the audience, your homework assignment is to think of the questions to make sure that anything you have, we can try to address. We have planned for time for that. So talking about patient considerations, toxicity management, what do we need to think about, Nancy, when we talk about toxicity or side effect management?
Sure. One of the first things that I talk about with patients is I try to get a very detailed assessment of their baseline other medical conditions. And obviously, the number one is if they have a history of hypertension, do they have a history of diabetes and thyroid dysfunction? Because those are the side effects that are probably going to occur when one is embarking on a combination immunotherapy and a TKI. Simple things like making sure they have over-the-counter medications at home. So if they do develop a change in their bowels and they need loperamide, they have it at home. In my practice, every patient will have a blood pressure cuff because the blood pressure is going to go up with these medications. And I give them a log. They will send me a picture of their log. They'll let me know if their blood pressure is going up, and we give them parameters and other things. If they're under the care of a cardiologist or their internist, we like them to communicate with them about their hypertension, because the last thing that we want to do is start interfering with a well-known regimen to control hypertension. And just, in today's world, we are really always looking at outcomes and ways in which we do make an impact, a positive impact for patients. And I think that by monitoring the blood pressure at home, we can see early on if we see a trend in their blood pressure, and we can have an intervention early so we don't have to stop their medication. Communication with the healthcare team if they have a change in their bowel habits. I don't want someone telling me they have, 8 episodes of watery diarrhea when we could have, controlled it earlier on, and again, perhaps eliminating a drug hold or discontinuation of medication. And then the importance of skin care. These patients might get rashes, they develop hand-foot syndrome, and these are things that they need to communicate with us as soon as possible so that we can start our interventions for them.
Fabulous. Now, side effects with the VEGFR TKIs. Virginia, do you want to talk about those?
Sure, absolutely. Well, Nancy did a lot of it for this class. As she mentioned, hypertension, really important when you're starting patients on this treatment that you make sure that their baseline blood pressure is well controlled. If you have a patient who's already uncontrolled, you're going to be in trouble in a few weeks. So we really try to maximize their blood pressure control before we put them on therapy. And as Nancy said, have them track their blood pressure at home, give them parameters for which they should call, and loop in their cardiologist or their PCP if they if they're seeing them more often than they're seeing us, so that they can make recommendations for which medications to add. Hand-foot syndrome is a really difficult side effect for patients if they develop it. Being proactive is really important, so really educating patients, if you're getting trouble with your hands or your feet, call us right away. Using a urea-based cream can be very beneficial. If you do develop redness, pain, ulcerations, a steroid cream can be helpful for that, as well as holding therapy. It's very important. A lot of times we have to encourage patients to let us know if they're having side effects because they're worried about us holding treatment, but it's really critical that we hold therapy, let them recover from that side effect, and then most likely dose reduce them, but with the goal of trying to keep them on therapy as long as possible. And so just encouraging them to be aware of these things, some proactive things they can do, put gel insoles in their footwear. They can avoid extremes of temperature with their hands and their feet, avoid a lot of friction so they get out of dishwashing, raking leaves, various things. I try to tell them all the benefits of this so that they don't, I had a golfer who came in and his, after golfing for 18 rounds, he really had 18 holes, I should say. He really had pain in his hands, and that was obviously, I should have forewarned him about that. Fatigue, this is a really tough one. Fatigue is just, it comes with so many of our therapies. It comes with the disease itself. It's hard to treat this effectively. I think trying to ensure a good sleep-wake cycle is important if you can. Encouraging patients to try to get enough sleep. If they feel like they need to take a nap in the daytime, that's fine, but try not to reverse their sleep cycles or sleep so much in the daytime that they're then up at night. Trying to get a little bit of exercise. I know that's a push for people with advanced kidney cancer. Some people don't feel well enough to do that, but if they can get a little bit of exercise, it can be very beneficial for helping them be tired at the end of the day and get better sleep. And if those things don't work, you can consider pharmaceuticals to help with trying to boost up their energy some. Diarrhea, that comes with almost all of our therapies. So again, as Nancy said, establishing a baseline for them, telling them to call us with any changes, letting them know what over-the-counter meds they can use, make sure they stay hydrated. If they do develop diarrhea, they need to call us in case they need to come in and get fluids, and having them monitor their weight in that setting. And think about food choices as well. Certain foods might trigger it. Maybe the brat diet needs to be instituted for a couple of days in that case. And mucositis is a really tough problem, very painful for patients. I've had to put some of my patients on narcotics because their mouth sores are so extreme. So again, trying to help patients know what to look for, that there can be sensitivity that starts out before you get a true ulcer. You can start with some steroid mouthwashes. Good oral hygiene is important. And just having them, again, know they can reach out to us for problem solving in this situation.
Fantastic. So I'm going to throw in a question now just to stimulate everybody's thinking of questions. Virginia, you talked about the hypertension. When we interrupt therapy, what do we need to think about? What is important for nurses and providers to think about with hypertension and antihypertensive meds?
Well, if you've maxed out their antihypertensive, I have people on 3 and 4 meds, and then I hold their therapy, and then they drop their blood pressure. So it's just, I tell them, even though you're off the treatment, I want you to monitor your blood pressure, and maybe we hold 1 or we hold 2, and I give them parameters and try to check in. But early on, I think when we didn't have such an understanding of that relationship, patients would become hypotensive.
Yeah. Thanks for sharing that, Pearl. Mm-hmm. So Zita, talk about the immunotherapies and our immune-related adverse events.
Yeah, the way I describe it to the patients, it's all the itises, basically. So unfortunately, with immune therapies, some patients may have no side effects, but then some may have several. And some can be very serious. The most common, I would say, is dermatologic, some rash, dermatitis. But then there are some other common ones, liver, hepatitis, and nephritis. So we always check labs before every infusion. We always educate patients to let us know about any new side effects. Diarrhea, we would worry about colitis. We worry if they suddenly develop new shortness of breath, cough. We worry about pneumonitis. So it's important that patients communicate to us about new toxicities, and that we always take a very thorough review of systems at each visit.
Fantastic, thank you. And then Nancy, combination therapies with our VEGF-IO combos.
I get stuck. I guess I am in the middle here. This is the real challenge for patients who are on combination therapy. I think we know very well the side effects associated with the VEGF-targeted therapy and also with the immunotherapy. But when they are combined, things change. I'll give you an example. If you're starting a patient on an immunotherapy agent and a targeted therapy, and one that has a black box warning, and you know that you need to get lab work about two weeks into the treatment, and all of a sudden you see those liver enzymes elevated, you don't know what it is. Is it the immunotherapy? Is it the oral agent? So what do you do? And these are the decisions that the experts have to make. We can, depending certainly on the degree of liver abnormalities, sometimes we might continue the patient a little bit longer, repeat the blood work, and if we see a trend increasing, then we're going to hold the oral agent because we can. Once you give an infusion of immunotherapy, it's given and it's gone. It's circulating. So when in doubt, I'm always much safer to hold the medication when you are in this situation. The side effects that overlap will be the skin rash, will certainly be the fatigue, the diarrhea, liver dysfunction, hypothyroidism, decrease in appetite, and sometimes an altered mental status. They're quite rare, the encephalopathies or the RPLS. These are things where patients they can develop seizures, they get intense headaches. The side effects will happen. The important thing is that you see your patients in a timely manner every 2 weeks. Keep a close tabs on them, monitor them with blood work, and then make the correct decisions of when to hold back the therapy. These treatments are not easy, but they are tolerable. And many patients might have a bumpy road the first 4 to 8 weeks of treatment, but then we get them to a place where they are able to tolerate both medications, and then they're on their way to feeling better, having a better quality of life, and as Virginia alluded to, some shrinkage of their tumors. So not to overlook the first couple months of treatment when most of these overlapping toxicities may occur, but know that a dose reduction or even holding, you will get the patient back on track and back onto their therapy.
Fantastic. Thank you so very much. So with that, I open the audience to questions that you might have. We've got a microphone we can pull from the back, and Amy can be our roving reporter with a microphone. But in the interim, I've got some excellent questions from our virtual audience. So the first one is for surveillance scans, okay? Taking kidney function into consideration, do you see a benefit in ordering abdominal pelvic scans with or without oral contrast, or with or without IV contrast? Okay. So how do each of you, let's all three of us answer that.
Sure. I mean, obviously our radiology colleagues help us with that. They're looking at the creatinine as well, and will give us guidance if they think we should do scans without contrast. So I think our cutoff is if a creatinine is over 1.5, we typically will switch to a chest CT without contrast, and then often we'll do an abdominal and pelvic MRI if the patient can have it. Sometimes we will prehydrate patients so that they can still get the scans, the ultimate scans that we want, but protect their kidney as well.
I think we have a similar practice in that We use a combination of MRIs for patients when we want to reduce the amount of radiation exposure. And certainly in my case study of the 25-year-old, we used MRIs. For patients who need CAT scans, sometimes every 12 weeks, we have to take into consideration a lot of factors. Their kidney function. Do we really, really need that contrast? And most recently, I think we don't always need the contrast, and we're getting, good images and pictures without having to increase the risk of kidney dysfunction from the contrast.
So, a lot of patients that I'm monitoring or surveilling are patients who perhaps have or have had metastasis to the pancreas and the liver, and to try to image those without contrast is very hard. The way I describe it to patients, it's like looking in the room with the lights off. You can kind of figure out where the bed is and where the chair is, but you can't see the texture of the quilt and the color and what have you, right? And so you lose a lot of detail by omitting the contrast. So we do, like Virginia said, try to adequately hydrate them or switch to MRIs with contrast.
Excellent, thank you. And thank you for leading into the metastatic setting, because that's what I was also going to allude to. So again, if you can give them IV hydration prior to imaging, we've made those arrangements with our imaging department. The nurse down there that starts the IV can give the hydration. So they're hydrating, and then they've got the oral prep while they're IV stripping. So those are things to think about as well. And again, as was alluded to by the panel, if you're evaluating chest-only disease, and you can do that without contrast in the metastatic setting, they've plateaued their response, you don't have to do IV contrast every single imaging time point. Again, your challenge is, as a clinical trials nurse, you may not have that flexibility, but in standard of care setting, you definitely need to individualize that recommendation. So super, thank you. Any questions from the audience? Yes, please, go for it.
I preface this with, I am a stage 4 patient about to celebrate my 4th year, clear cell. First of all, thank you all for keeping us alive. We really do appreciate it. One thing just I've learned throughout this, because I have a stage 4 community, Facebook community that has over 1,000 people in it. Most people think palliative care is hospice. Hospice is a piece of palliative care, but I will tell you, I've been taking advantage of palliative care since day one, and they are incredible where I am at. So I would just recommend that you educate patients, because you say palliative care and they think end of life.
Mm-hmm.
Right.
Excellent point.
Two quick questions. One, I am on Ipi-Devo and only on Opdivo right now, and I'm not getting off of it. And I have seen no definitive, because like your case study, I'm advocating for myself, and my insurance keeps covering it. And I am stable with a couple of hiccups once in a while. But I've seen no definitive studies. I've seen 1 year, I've seen 2 year, and I've seen a lot of patients on it for more than 2 years. So I'm just curious, have you guys seen any definitive works on what's the optimal time to stay on the immunotherapies? And the second question is the overall survival rate of 15%. Does that take into consideration the checkpoint 214 and some of the other studies that are showing up to a 48 to 50% with immunotherapy?
The challenges with the statistics is they're behind the times. Yeah. So who wants to answer his first question?
About staying on therapy. I don't know if there's any data at 24 months to stop, but I know that that's the discussion.
It's individualized.
Yeah.
Zita?
So just to backtrack a little bit, one point in our institution, several years ago, almost 10 years ago, we renamed palliative care to supportive care, because I think that's a much better designation. So I call it supportive care. To your point about the, you're right. I don't think I think that data, hopefully, they're going to be, the Nivo-Ipi data is going to be coming out. The 10-year data is going to be coming out soon, and we'll be looking at those patients and seeing. At the same time, I've had patients develop, even after they've been on therapies for a long time, developing these IO toxicities down the road. So that's the balance, right? So if and especially if a patient is if they achieve a CR, Do you need to keep treating them? That's the other side, side of the coin. So we don't want to overtreat patients and potentially put them at risk of toxicities either. But if they still have a tumor in place or they're still shrinking, we would, in our personal practice, is to continue them on treatment. We won't automatically stop them. I don't think there's anything magical about 24 months necessarily.
Right. It's the way clinical trials have been designed. So we're at the mercy of the way the clinical trials are written and what the thought was at the time that trial was written. Because by the time we're open to enrollment, the thought may have changed, but the protocol may not be able to. But while we're on that same subject, 2 questions for the group. You talked about treatment-free survival, TFS. Can you explain, in case some of our audience is not familiar with that term? Because that leads into Zita's response and your question.
Yeah, I think it's a fairly new term, and it's important for a lot of patients to have time away from treatment completely. If you're thinking, when we had single-agent TKIs, patients were on those forever, essentially, along with all the side effects that we've talked about. And the immunotherapy can offer them a chance to get off treatment and really kind of resume their normal life. Their quality of life gets back, especially if they don't get IO toxicity. And so it's really about improving patients' quality of life and allowing them some time away from therapy. And I think it's been, obviously one of the great hallmarks of immunotherapy today. And just to follow up on your question about being on IO for a long time, I've done this a long time. And so we had patients on treatment for 7 years, and he was doing great. And then all of a sudden, he got very severe Meniere's disease, like debilitating. And ultimately, and I was like, I've never seen this. That's not it. And, but we stopped his treatment and he got kind of better and steroids helped some. So, I've had patients even go off therapy after 4 or 5 years and they're off for 6 months and then they develop sudden renal failure. And we're all like, what the heck? But it was just a delayed toxicity. So, how much is too much? And we just don't know that. I think you just be an aware patient and then have a team that knows what they're doing. And then also just remind the patients that they always have to tell their providers. I had IO, I had immunotherapy. I stopped it 6 months ago, but could this be IO related? Because I can't tell you how many times patients show up in emergency rooms and people are barking up the wrong tree. And it's really about IO toxicity.
Right. And one of the things when I educate providers is that you need to always be thinking about the potential for the IO etiology. No matter front line, second line, even if they're on a TKI and you've got what might be an itis, you need to evaluate it and assess it. Most importantly, along with that is patient and caregiver education. Because if they're not aware of it and they're not aware to ask it and to think it, it ends up under the bridge and nobody looks at it. So those are key things. So excellent, thank you. So I've got another question from the virtual audience. At what point are you using mutation testing and comments on belzutifan use? So let's talk about the mutation testing.
Oh, sure. Well, we do a lot of genetic next generation sequencing on our patients. It's on the tumor. It's not on the patient. And we do it almost for every patient that we see. And then we're finding the genetic mutation. And if we have a drug that can match that, we will treat the patient with that drug. It's generally not used first line because patients say, well, why can't I use this right away? We're kind of reserving it for second and third line therapies for our patients. And most recently, we've had a lot of success with getting belzutifan approved for our patients whose tumor has the VHL mutation. They don't have VHL disease, but the tumor is showing the mutation.
Great.
And that's been very encouraging.
Great, thank you. A couple more questions from our virtual audience, and that is, what about multidisciplinary management? And how do we identify providers to help us with these adverse events management? Particularly, the focus is on the community practice. Because we have blessings at the tertiary care centers that our colleagues in the community don't. And I know for me, I'm more than willing to tell a patient, you need to drive an hour to get to the Cleveland Clinic. We now have a multidisciplinary cancer clinic on Friday afternoons, and we get multiple disciplines there together. How do you do that in the community setting other than advocate for the patient?
So I guess it could be broken down to two questions: multidisciplinary within the diagnosis, but then also managing IO toxicities.
Yes.
Sure.
So I mean, for purposes of IO toxicities, it's true. Experience matters, and particularly depending on, I think some IO toxicities are certainly much more difficult to handle than others. Dermatitis, grade 1, grade 2, usually topical steroids can handle it. But, if you have somebody who presents with some of the rare, more serious toxicities, myocarditis, Guillain-Barré, fortunately they're very rare, but because they're rare, again, this is where experience matters. And unfortunately, I think this is where, you do really need to be at a tertiary center, because it's a day-to-day management. Those are hard. Those are very hard to manage. And trying to do it remotely at a small hospital where they just don't have the resources. They don't have phoresis units. They don't have, the ability to do some of the things that we would do in those situations. So it's in those unique situations, I think that's where specialty centers are called for.
Great. Thank you very much. So for the sake of time, really want to share with you that the Kidney Cancer Association is really doing a lot to increase knowledge and awareness and information out there. You've got the QR code there for several of the resources, including, as I mentioned earlier, the video library and the patient video library. So please make sure you're aware of that, you use it, you share it with your colleagues. That would be extremely important. And then for those of you that are on the virtual, please make sure that you complete the evaluation, and that will come up in a pop-up browser. So very much appreciated to help us with that. We've done our best to provide you with a 30,000-foot orientation to kidney cancer, but we need the help of what is needed to make this better. So again, thank you to Merck for the opportunity to have this workshop this evening, and thank you to all of you that attended this evening. And I think my final words are on biomarkers and other things. Stay tuned. We're going to learn a lot in the next 2 days. Sleep well.